My presentation today was on the prevention and the management of adverse events in patients with relapsed multiple myeloma. So these days, myeloma treatment paradigm has changed from single agent, short-term treatment to treatment with combination of drugs for months or even years. And because we are using more drugs, longer treatment, patients have more exposure to drugs and are more at risk of developing adverse events. It's very important that we keep in mind that the development of adverse events can not only decrease the quality of life of patients, but also reduce their overall survival. And therefore, we should make any effort we can to prevent, recognize these adverse events and treat them appropriately if they occur. So first of all, I discussed the adverse events that can occur with the class of drugs we call proteasome inhibitors. So the first in class proteasome inhibitor is Bortezomib, and we have now more than 10 years experience of treatment with Bortezomib. And so the major side effect, even with sub-Q administration, is peripheral neuropathy. Despite having experience of more than 10 years with Bortezomib, peripheral neuropathy is still an issue. And so it's not only about grade 3 or 4 toxicities. For instance, with neuropathy, also grade 1 and particularly grade 2 neuropathy, according to the common toxicity criteria, is very important for patients. So we need to think of appropriate dose adjustment, prolonging the interval between the injections, and in other words, try to prevent the neuropathy, because once it's there and it's frequently painful neuropathy, it's very hard to treat. And you can go for some symptom alleviation, but we should try to prevent it. And I've also briefly discussed the other proteasome inhibitors. Ixazomib, which is given in combination with lenalidomide and dexamethasone, can cause a little bit more thrombocytopenia, some diarrhea, some skin rash. With Carfilzomib, there can be an issue with cardiovascular toxicities in terms of hypertension and very rarely cardiac failure. But these days we know how to try to prevent those adverse events by selecting the right patients, and if any cardiovascular issues are there, to try to control them before starting the treatment whenever possible. And doing so, we can definitely reduce the risk of unforeseen severe cardiovascular adverse events. I have briefly talked about monoclonal antibodies, Daratumumab, Isatuximab, Elotuzumab. So with these monoclonal antibodies, there can be infusion-related adverse events. So we should give appropriate prevention with steroids, with paracetamol, with antihistaminics. And we have to know that, for instance, with Daratumumab, it occurs in 40% of the patients with the first infusion. But later on, it's very, very rarely seen if you give appropriate prophylactic measures. With Elotuzumab, it occurs in around 10% of the patients, and also in a majority only with the first infusion. Patients with chronic obstructive pulmonary disease are a particular subgroup, and so if we want to treat these patients with Daratumumab, we should also think of post-infusion medication with inhaled beta-2 mimetics with inhaled corticosteroids. And then I have also very briefly discussed on the adverse events that can occur with IMiDs. And so to start with lenalidomide, we give the combination with Daratumumab. DRD is currently a cornerstone of myeloma treatment at first relapse in many centers. Keep in mind that by adding Daratumumab to Lendex, there will be a slight increase in hematological toxicities and also in infection rates. So upper respiratory tract infections, but also pneumonia can occur more frequently. And then with pomalidomide, we know that Pomdex is associated with grade 3 to 4 neutropenia in half of the patients, but by adding a third drug, which is currently frequently done, like cyclophosphamide. In the near future, this will be anti-CD38 antibodies like Daratumumab and Isatuximab. This will also increase the infection rate, and so appropriate prophylactic measures should be taken whenever needed. And then very finally, so the myeloma treatment field at relapse is moving very fast. We see the second generation of monoclonal antibodies coming very close to entering the clinic. So there is the compound of GSK, which is a conjugated anti-BCMA antibody. Phase 1 results have been published very recently. And interestingly, this compound is also associated with some ocular toxicities, like blurred vision or photophobia. And that's something new. And of course, we need to await more long-term results and see to what extent we can prevent it and whether it's fully reversible in the majority of patients. With advanced cellular immunotherapy, CAR T cells, there has been last week the publication of the phase 1 data from the BB2121 anti-BCMA CAR Ts. And so this product is highly effective, but there is grade 4 neutropenia in 80% of the patients. There is the cytokine release syndrome in 3/4 of the patients, and neurological toxicities in 42% of patients. But fortunately, these CRS and neurotoxicity are most of the time mild to moderate. So my conclusion was basically that the myeloma treatment paradigm is rapidly changing in relapse, and we are moving to treatment with combination of drugs for prolonged treatment. And so to preserve the quality of life of patients, we should think about possible adverse events, make every effort to try to prevent them. By using more and more active combinations, we will see also more immunosuppression in many patients, especially in patients that have already received several treatments and that have a suppressed or exhausted immune system. And this also will make us responsible for trying to prevent or rapidly act whenever there is an adverse event occurring.